at Johns Hopkins University, 1988. She was a postdoctoral fellow in the LPD, that is Lab of Parasitic Diseases at the NIH. She completed her fellowship in infectious diseases, the University of Iowa Hospitals and Clinics. Was appointed as an assistant professor in the Division of Infectious Diseases prior to returning to the LPD in 1997, where she is currently a senior clinical investigator and head the human eosinophil section. In the early stages of her career, she focused primarily on questions related to the diagnosis, treatment, and pathogenesis of the filarial parasite Loa loa. Since returning to the LPD, however, her research program has expanded to include basic and translational research related to the role of eosinophil and eosinophil activation in disease pathogenesis. The goal of her lab is to develop novel diagnostic tools and treatment approaches for hypereosinophilic syndromes and other conditions associated with marked eosinophilia, including helminthic infections. She is the past president of the International Eosinophil Society, recipient of the Society's 2015 Service Award, fellow of the American Society of Tropical Medicine, recipient of 2004 Belle K. Ashford Medal for distinguished work in tropical medicine. She has served on the editorial boards of Blood and the Journal of Allergy and Clinical Immunology, numerous advisory committees, and expert panels related to her work on eosinophilic disorders and the neglected tropical diseases. She's an author of more than 175 scholarly articles, reviews, and textbook chapters. Friends, it's my pleasure this evening to invite Dr. D Kilon to deliver her talk on eosinophilia in hematological practice. Thank you so much. I'll stop sharing and invite her to share her screen and deliver this talk. Thank you, Dr. Kilon, for accepting this invitation. We are honored and we are looking forward to your lecture.
So Dr. Agarwal, thank you very much, and thanks to the committee for inviting me. I'm sorry that I'm not in India with you. The last time that I was there was 4 or 5 years ago. I changed the title of my talk a little bit from your title to Eosinophils, the Good, the Bad, and the Beautiful, and I'm hoping that I'll be able to convince you that they're mostly beautiful. So I have no disclosures. I work for the government. We're not permitted. None of the drugs.
Madam, could you please share the screen?
Oh, I'm sorry. Hold on. But it looks to me like I'm sharing. So let's see what happens. Okay. Is it sharing now?
Yes.
Okay, it looked to me like it was sharing. I guess it was not. So I have no disclosures. None of the drugs being discussed have been approved by the FDA in the United States for the treatment of eosinophilic disorders, except for imatinib and mepolizumab. And I should have updated this. It's now approved also for hypereosinophilic syndrome in the United States. A number of drug companies have provided study drug or clinical trial support, but this is all under research agreements with NIAID, and I derive no personal benefit, unfortunately. Okay, so now, of course, we tested this before and everything was fine. There we go. So what I'm going to do is provide a brief introduction to eosinophil biology and function, which is probably unnecessary for this audience, but I just want to make sure everybody's on the same plane. I'll then give you the most recent definition and differential diagnosis of hypereosinophilic syndrome, and then finish up with talking about some changes in our therapeutic approaches. In terms of disorders that are associated with eosinophilia, this is kind of the classic textbook list. The difference between most of these disorders and hypereosinophilic syndromes, and the reason that my group has focused on this particular disorder, is because eosinophils are by definition important in hypereosinophilic syndromes. And so it's our feeling that if we, excuse me, hold on one second. I apologize, the disadvantages of presenting on a Saturday from home and having dogs. Anyway, so the reason we study hypereosinophilic syndromes is because the eosinophilia in these disorders is thought to be primary in causing the disease. We then use what we learn from those disorders because it has implications on more common things associated with eosinophilia, such as allergy and asthma.
Madam, you need to unmute yourself, Dr. Kilon.
Sorry, I've done this a million times and I still seem to be having trouble. Anyway, the reason we focus on hypereosinophilic syndromes is because of what we can learn in terms of other more common disorders such as allergy and asthma and parasitic infection. For some reason, there we go. So eosinophils are known mostly because they cause pathology, and they can do this through a variety of ways. They have direct cytotoxic effects. This is primarily due to the granule proteins, which are in their secondary granules shown in the electron micrograph on the top right by the red arrow. These granules also contain almost every cytokine and chemokine that's been described in preformed form. And these can be released selectively. This can lead to recruitment of other inflammatory cells, initiation of fibrogenesis, and hypercoagulability. They also, when they become activated, in addition to this selective secretion of granule proteins, which is called piecemeal degranulation, they also make lipid bodies, which are shown by the black arrow, and these contain reactive oxygen intermediates and a variety of lipid mediators. When eosinophils are activated and they do this, a number of things can happen. And it turns out it doesn't really matter what the disease driving the activated eosinophilia is. So this is the heart from a patient of ours who had chronic eosinophilic leukemia. It turned out that he actually had PDGFRA positive disease, but was discovered much too late and ultimately died of his endomyocardial fibrosis, shown by the red arrows on the right. But down here at the bottom is a heart biopsy from a patient who also had endomyocardial fibrosis. The staining in the bottom right, the green staining, is staining against major basic protein, one of the eosinophil granule proteins. Only this patient had loa, a filarial parasite infection. And that's really just to illustrate that the end pathogenesis can be very similar, irrespective of the underlying cause. In the last, I'd say 10 years or so, there's been some interest on the other side. So eosinophils clearly can cause pathogenesis, but why do we have them at all? Originally, they were thought to be involved in defense against parasites, but much of the data that we have today suggests that really that may not be their major role. And in addition, as parasites become less and less common in the world, we still have eosinophils, and the absence of eosinophils is extraordinarily rare. And so there's been a lot of interest in their role in homeostasis. The many things shown on this slide, including tumor surveillance, tissue regeneration and remodeling, innate and adaptive immunity, and metabolic homeostasis, have been mostly shown in mice and mouse models, but there is data for several of these from humans. And I think that this is going to turn out to be very important for a number of reasons. One reason is that we now have drugs, as you'll hear about in the end of my talk, that completely deplete eosinophils in humans. And so if eosinophils are important in homeostatic function, then questions arise about what effect that's going to have in the long term on people. So I'm going to move on to hypereosinophilia and hypereosinophilic syndrome. And this definition is one that's been in quite a lot of flux. And I'll say up front, since you're hematologists, that my definition differs from the definition of the World Health Organization. And the reason it differs is because of the implications with respect to diagnosis and treatment. And so hopefully by the end of my talk, you'll appreciate that. So the way that we define hypereosinophilia at the NIH, and this has been the subject of several consensus conferences, and so we're not alone, is blood eosinophilia greater than 1,500 at least twice, so that it's not lab error, or evidence of prominent tissue eosinophilia associated with marked blood eosinophilia. And so this creates a huge umbrella of patients who have too many eosinophils. if you then have evidence of end organ damage attributable to the eosinophilia, we would call all of these conditions a hypereosinophilic syndrome, not necessarily an idiopathic hypereosinophilic syndrome, but a hypereosinophilic syndrome. And if you use this definition, then secondary causes of eosinophilia, such as parasitic disease, as I showed you previously, or allergic diseases, drug-induced eosinophilia, or neoplasms, all of which can cause hypereosinophilia or hypereosinophilic syndrome, are included in this umbrella. It's just that they're approached differently, and I think that's really very important. So if you have this huge umbrella, then you need to do something to make sense of the chaos. And so what we've spent a lot of time in my group over the last 10 or 15 years is trying to identify what we call clinical subtypes of hypereosinophilic syndrome. So dividing the pie into things that might have different underlying causes and different approaches. And so this is the pie from our NIH cohort currently. And what you can see is about 20 to 30% have a myeloid cause. That means they have a primary eosinophilic disorder. And I'll talk about that in a little bit. Another 15, 20% have lymphocyte-driven eosinophilia. So their lymphocytes are abnormal, but their eosinophils are normal. And I'll talk about that as well. A big chunk is what we call overlap. These are specific clinical syndromes or single organ disease that overlap with our definition of HES. So this would be things like eosinophilic granulomatosis and polyangiitis, what used to be known as Church-Strauss syndrome, which has been studied over many, many years, has a lot of data in terms of approaches, but overlaps in definition with HES, or things like eosinophilic gastrointestinal disease. Associated, the gray, are patients that were referred to us for unexplained eosinophilia, but were found to have an underlying cause that was treated differently. There's a very small number of families that have a familial form of eosinophilia. And then the rest we still put in idiopathic as we try to figure out which category they might fit in. So I'm going to go through some of these one at a time. So the myeloid version of HES is one of the things that's obviously of most interest to hematologists. And so I thought I would tell you the story of how we came to this broader definition that differs from WHO. Quite a long time ago, in the early 2000s, a patient was referred to me from a military physician in the US who had very classic hypereosinophilic syndrome with endomyocardial fibrosis and pulmonary infiltrates. He had an elevated serum tryptase. I wasn't quite sure why they had measured this. His bone marrow did not show evidence of increased mast cells on routine H&E, but it was slightly elevated at 25. That patient went on to transplant. This was prior to the days of imatinib and FIP1L1 PDGFRA, but it caused me to think, well, I wonder if serum tryptase is elevated in other patients with HES. And so we looked across retrospectively a group of our patients. And what we found was that the patients with D816V KIT hypereosinophilic syndrome, they had very, very high tryptase levels. And these would be what would now be called systemic mastocytosis with an associated hematologic disorder. Patients with Helminth infection and other idiopathic eosinophilic disorders really did not. But our HES patients fell into two categories, those with elevated serum tryptase and those with normal serum tryptase. And when we looked at who the ones with elevated serum tryptase were, they were all men. They had evidence of other lineage involvement. They had very dysplastic eosinophils and myeloid precursors in the periphery. They had splenomegaly, hypercellular marrows, and increased serum B12 levels. In addition, because this was retrospective, we knew that 30% of them had died within 3 years of their diagnosis. And so we were very interested in this group of patients when one of our patients decided that, using the following logic, many drugs used to treat CML are used to treat HES. Therefore, the new drug imatinib, recently approved for CML, would be good for me. And so he got a friend of his who was a physician to prescribe it for him and responded. He published his own case in the e-literature. So a number of us saw this case report or talked to the patient. And so we began to treat some of our patients with aggressive disease with imatinib. And what we found was that this group of patients who had this phenotype were the ones that responded. So that started the race for why they responded to imatinib, since they didn't have BCR-ABL, and the person who won the race was Jan Kool's. And what he showed was that this was caused by an interstitial deletion in chromosome 4 that led to a constitutively activated fusion tyrosine kinase that we all now know as FIP1L1 PDGFRA, and that was sensitive to imatinib. This can be detected by RT-PCR or by FISH, although I will say that our data suggests that the FISH is less sensitive. And other fusion partners and point mutations have been described, and these are detected neither by RT-PCR or FISH. So I think keeping this clinical picture in mind is actually important, because otherwise you'll miss patients that have this disease. And importantly, they were all responsive to imatinib. So we now put this into a group of disorders that we call myeloid variant HES. More than 80% of those patients will have a PDGFRA positive mutation. Other mutations that are recurrent in this group of patients presenting with marked eosinophilia and eosinophil complications are PDGFRB, FGFR1, KIT, and JAK2. There are also patients who present with abnormal cytogenetics or increased blasts that would be classified as chronic eosinophilic leukemia, not otherwise specified. And then there are always about 20% of our patients that present just like these patients, but have idiopathic HES that we call MHES, or myeloid variant HES. And I'll talk to you in a little bit about the treatment of these patients and why we think it's important to think of this group of patients as a group and not as individual diagnoses. The PDGFRA associated MPN patients have a couple of things that are a little unusual. They usually do have bone marrow mastocytosis, and there was a lot of controversy early on about whether this was systemic mastocytosis or an eosinophilic neoplasm. Most of the time, their disease is actually eosinophil driven, so I would argue that they have an eosinophilic myeloid neoplasm, and they don't always have bone marrow mastocytosis, and they never have classic symptoms of mast cell activation. More recently, there have been a couple of patients who don't have eosinophilia, so again, I think this is a little confusing. Fibrotic complications such as endomyocardial fibrosis are common, but they can present with a wide variety of clinical manifestations. We've had people present with eosinophilic colitis, with most recently a patient who presented with eosinophilic duodenitis. So just because they don't seem like they have a myeloid neoplasm isn't a reason to discount this. They can also have some unusual dermatologic presentations, including mucosal ulcerations and lymphomatoid papulosis. There was a case published in 2010. We published a case in 2008, and there have now been several other cases published. And finally, these patients, for whatever reason, have some unique complications of imatinib therapy. The first is myocardial necrosis, and we've seen 2 patients develop this. These are patients who have pre-existing cardiac involvement, get put on imatinib therapy. Their eosinophil count comes down dramatically, and they develop acute myocardial necrosis. We treat any patient with an elevated serum troponin with steroids prior to imatinib therapy. That's not 100% protective, and we admit them to the hospital for initiation of therapy. We've also had 5 or 6 patients who've developed hepatic necrosis while their disease was in remission after more than a year of imatinib therapy. These patients, if you stop the imatinib, it goes away. If you restart the imatinib, it comes back, unlike what's seen early on in therapy where you can often reinitiate therapy. And so these are just things to keep in mind. The 5 patients that we follow who had late onset hepatic necrosis are all in remission on nilotinib. So moving on to lymphocytic variant HES. So this is really the flip side, but also of importance to hematologists because of the overlap with lymphoma. These patients have populations of phenotypically aberrant or clonal T cells that make eosinophilic poietic cytokines. It's equally common in men and women. I should say that the myeloid variant PDGFRA is almost exclusively in men, although we've seen 3 women, but the other types of myeloid HES show an equally common predominance in men and women. These patients often have skin manifestations, but again can present with almost any organ involvement. They typically have elevated serum IgE and TARC levels, but not always. And they may either have lymphoma at presentation or progress to lymphoma over time. Although when they progress to lymphoma, they usually develop cytogenetic abnormalities or lymphocytosis, and frequently will become more and more refractory to therapy as a hint that that's what's going on. These patients don't respond to imatinib. This is just a picture of what the cytokine production looks like in one of these patients. So this was a patient of ours who had a CD3 negative, CD4 positive lymphocyte population shown here in the upper left. That represented 18.6% of his T cells. These cells were making lots and lots of IL-4 and IL-5 and very little gamma interferon, in contrast to his normal T cells, which made very little IL-4 and 5 and substantial interferon gamma. The IL-4 drives the high IgE and the IL-5, the eosinophilia. There are some novel variants of lymphocyte variant HES. My favorite one is this one. This was a 36-year-old man who presented with recurrent monthly episodes of bilateral hand and foot swelling. They've been going on for 3 months. And so we measured his blood every few days for 70 days. And what you can see here in the red line is his eosinophil count going from 0 to 10,000 and then coming back to normal without any intervention. That was preceded by a dramatic rise in IL-5 and then post-seeded by a rise in granule proteins in the blood and clinical symptoms. This is known as Gleich syndrome, and this is a picture of the little girl who was in the original paper from Jerry Gleich. You can see her swollen and not swollen. This can be really dramatic. They can gain 30 or 40 pounds every month. What we now know, because of work done by Panise Khoury in my group, is that this is a multi-lineage disease. So it's not only the eosinophils that cycle, the neutrophils cycle, the lymphocyte cycle, and all of the patients that we've studied to date have clonal T cell populations that also cycle, the vast majority of them being CD3 negative, CD4 positive, although one of our patients has a double positive clonal T cell population. Moving on to familial eosinophilia. So as I said, this is extraordinarily rare. There are eosinophilic disorders that can be familial, eosinophilic GI disease and eosinophilic granulomatosis. Both can run in families, but hypereosinophilic syndrome is very, very rare in families. We follow 2 families. The largest family is shown on the right. Both of the families we follow have autosomal dominant disease. In the largest family, the gene was mapped to chromosome 5q31 to 33. This is the home of the cytokine cluster. They have eosinophilia at birth. It's remarkably stable over time. This family has been followed since the 1980s, and they have remarkably stable eosinophilia during that time. Only a small subset have developed clinical manifestations. Most of them have eosinophilia from birth to death and are just fine. And the lack of clinical manifestations is associated with a relative lack of eosinophil activation compared to other eosinophilic disorders. We spent a lot of time trying to identify the cause of this disease, and Sen Babu from India was a postdoc in my lab, and she was able to show that this is due to dysregulation of IL-5 message expression. All of the cells in these patients' blood make IL-5. They're B cells, they're monocytes, they're neutrophils, and we have identified a SNP that we believe is responsible. I should, by hopefully the end of the summer, know whether that's in fact the case. We're doing CRISPR-Cas experiments to try to document that that's the cause. So these patients are really kind of like IL-5 transgenic mice. The mice also don't develop disease unless there's a second hit. Overlap HES, as I said, this is single organ disorders or disorders that overlap in presentation. The reason it's important to recognize these is that the therapeutic approach may be quite different. A patient with eosinophilic gastritis might be treated with diet or with swallowed steroids, despite having a very high peripheral count. And we don't really pay that much attention to the peripheral account because they don't develop other complications. Similarly, a patient with EGPA might be treated with a slightly different approach than a patient with idiopathic HES. So I think it's important to recognize these. And then finally, we're left with idiopathic HES. So if everything else is excluded, because of changing definitions of overlap, I'd say about 30% of our patients are diagnosed with idiopathic HES. Interestingly, a small subset of these patients are completely asymptomatic and have no evidence of end organ involvement. And one example of that is shown over here on the right. This patient presented with 6,000 eosinophils, and his eosinophil count over 30, actually now 40 years, has been remarkably elevated, with one exception. His eosinophil count was normal when he had acute appendicitis. And that's just to remind me to tell you that fever and infections can drop the eosinophil count even in HES patients, but they rebound back to normal once the fever and infection have resolved. We don't know how to separate these patients who will remain asymptomatic from the patients that have HES or will develop HES. We spent a lot of time looking at this. We have a publication on it, but are actively trying to identify ways to distinguish them. And then I'll end with associated HES, because I think this is the most important for any subspecialist. As I said, secondary causes of eosinophilia can mimic idiopathic HES. The patients that are seen on my protocol are referred because they had HES of unknown etiology. Despite that, 13% of them were found to have another cause. What were those causes? Helminth infection, drug reactions, neoplasm, immunodeficiency, and other things. And I will say that I'm a parasitologist with background in infectious disease. If I think that the person has a Helminth infection, I don't enroll them on this protocol. I have a parasite protocol. So these were cases that fooled me, despite having gone through all the records. And so what are these patients? I'll give you 3 examples. The first was a 50-year-old Iraqi rug salesman who presented with pruritus and a total body rash. His eosinophil count was 30,000. We did a huge evaluation, found nothing, including bone marrow and CT scans and PET scan. He was only on pancrease as a medication over the counter. I asked him to stop it and everything went away. Now you're going to say, well, yeah, but that's coincidence. And he thought that too. But 6 months later, he had gastric upset, took the pancreas again, and the whole thing came back. So this was drug hypersensitivity. A 76-year-old man with CLL was referred to me for unexplained asymptomatic eosinophilia from a hematologist. He did have CLL. He had an eosinophil count of 4,000. And the question was, did he have an associated eosinophilic problem? He had taken quite a good travel history, but when I saw the patient, it occurred to me that he was 76. And so I asked him, well, were you in the military? And he said, oh, I don't want to talk about that. And I said, well, why not? He said, I was a prisoner of war in Southeast Asia. This patient had strongyloides. He was treated for his strongyloides and the eosinophilia went away. Unfortunately, it did not cure his CLL. And finally, and perhaps most disturbingly, a 22-year-old presented asymptomatic for a soccer physical, but was found to have an eosinophil count of 34,000. He saw a hematologist who did a strongyloides serology, I'm not sure why, and HIV testing and iron studies, and told the patient that he should just come back and have it rechecked. The patient said, well, I'm going to Iceland on vacation. He said, that's fine, come when you get back. So he came back and he had an eosinophil count of 68,000. At that point, the hematologist said, well, you should probably have a bone marrow. And the patient said, but I have exams next week and I feel fine. And he said, that's okay, you can wait. He then ran into somebody who knows me. And so he called me. I said, have the patient call me. We brought him in the next day, did a bone marrow. He had pre-B cell ALL. So these, it's really important to think about what doesn't fit. A rising eosinophil count with that kind of speed did not fit with a benign disease, and he needed an emergent evaluation. He's now doing fine post-chemo. So why is it important to differentiate between these subgroups? Well, I'm going to get to that now as I talk about treatment. Our general approach to treatment is the following. Is it potentially life-threatening? If somebody comes in with a stroke, with cardiac involvement, and I really am worried that something horrible is going to happen to them from the eosinophilia, we use high-dose steroids as our first line. If we know or we think that there's a high likelihood that they have a myeloid disorder, we might add imatinib at that point, and I'll explain why in a minute. But assume that they don't have life-threatening disease or that you've calmed them down with the steroids. The next question is, do they have a secondary treatable cause? And I will say that we also will give ivermectin as a single dose to anybody getting steroids if we think there's any possibility that they might have strongyloides. So after you decide that there's not a secondary treatable cause, then really the next thing we do is try to identify the clinical subtype, and this is why. And so I'm going to describe this in the context of a case. So this was a 54-year-old woman who presented with an 8-year history of marked eosinophilia, sinusitis, nasal polyps, urticaria, dermatitis, and dyspnea, and had an eosinophil count of 23,400. Evaluation revealed no evidence of myeloid or lymphocytic variant HES, but she had endomyocardial fibrosis with severe mitral regurgitation. She underwent valve replacement and tricuspid repair, was treated with prednisone and did not respond. And so I will come back to her in a minute. Conventional therapy for HES, really the most commonly used drugs even today, are prednisone, hydroxyurea, interferon, and imatinib. And about, I guess, a little more than 10 years ago now, Princess Abagu, when she was in the lab, collected data from 12 centers, 188 patients with HES, and looked at what the response to therapy was at 1 month to monotherapy. And as you can see by the number treated, the vast majority got prednisone monotherapy, 64 patients got hydroxyurea monotherapy, 46 interferon, and 68 imatinib. And if you look at the response rate, and I don't know why my numbers disappeared, but the top is 100%, the highest response rate in terms of complete response at 1 month is from steroids. And if you add in the partial responders, the response at 1 month is close to 85%. And so that's why we start with steroids. Steroids act quickly. They have a high rate of response in all comers with hypereosinophilic syndrome. If you look at hydroxyurea and interferon, they have about a 30% complete response rate, another 30% partial response rate, but they both take several weeks to work. And imatinib, although it has a similar complete response rate, has almost no partial response rate, and I'll get to why that is in a minute. But if you look over the long haul, what happens to those patients, the vast majority of them stop their therapy. Almost half stopped prednisone and 3/4 stopped the other drugs, primarily because of lack of efficacy. But in the case of hydroxyurea and interferon, a substantial proportion also stopped due to medication intolerance. So we need better therapies. So I'll start with imatinib. With the myeloid variant. So one of the things that Panisse Khoury and my group has been very interested in is predicting response to therapy. And one of the first things that she looked at was factors that might predict treatment responses in PDGFRA negative HES. And what she found was that the best predictor was actually these clinical subtypes. And as you can see outlined in green, the myeloid patients really don't respond to steroids. The LHES patients, the lymphocyte variant, respond, but often require highish doses. 0 to 10 milligrams is white, light gray is 11 to 20, more than 21 is the third color, and the darkest is no response. If you look at idiopathic HES, much higher response rate and to lower dose. Exactly the opposite is seen with imatinib. So if you look in the blue bars, that's PDGFRA positive patients, and we already know that they have a mutation that's sensitive to imatinib, and essentially 100%, whether in our prospective trial of imatinib or in retrospective trials, respond to imatinib. There's only one case of primary resistance that I'm aware of in the literature. If you look at PDGFRA negative patients that fit into that clinical subgroup of myeloid HES, though, what you find is that we got about a 50% response rate, whether in our prospective trial or looking retrospectively. And if you look at patients that don't have those clinical features, so where your clinical suspicion of a myeloid neoplasm is low, none of them respond to imatinib. So these two treatments are really opposite sides of the coin. So what about targeted therapies? And a lot of the work that I'll present here is from Fei Lai Kwang, who was an allergy fellow in the lab, who's now at Northwestern. And she performed studies looking at both IL-5 and IL-5 receptor antibodies. I won't talk today about, I don't believe, about Siglec-8 antibodies or about the other tyrosine kinases we're looking at, but I will, if I have time, talk a little bit about a drug called dexpramipexole. Sandhya Panch, who's actually at NIH, but just getting ready to move to Stanford, and is a hematologist, helped me with the study of dexpramipexole. So why IL-5? And so I'm a parasitologist. I need to show you at least one life cycle. This is the eosinophil life cycle. And what you can see is that IL-5 is important at every stage of the eosinophil life cycle. It's necessary for their growth and differentiation. It's important in sustaining them in the tissues. Eosinophils normally are only 1% to 2% of our blood cells. They're only in the blood for about 18 hours. And IL-5 receptor is found only on eosinophils, basophils, and mast cells, and that's important going forward. So there are 3 drugs that target the IL-5 receptor axis that are currently available in the US for asthma. Mepolizumab and reslizumab are anti-IL-5 antibodies. They essentially deprive eosinophils of their food and cause them to undergo apoptosis. These drugs deplete eosinophils in the tissues, but only about 50%. And then there's benralizumab, which is an antibody to IL-5 receptor, but which is afucosylated, which causes enhanced ADCC through NK cells binding the Fc gamma R3 receptor. And so these are the drugs that I'm going to talk about. And benralizumab completely depletes eosinophils. So the first of these drugs that we looked at in HES was mepolizumab, and in 2002, a placebo-controlled randomized multicenter trial was initiated in 85 PDGFRA negative patients. These were patients who required high-dose steroids, and they were given mepolizumab or placebo, and then we tried to taper their steroid dose. What's shown on the left is the primary endpoint, which was a prednisone dose of less than 10 milligrams per day for more than 8 weeks. And you can see 85% met the endpoint. But what was most dramatic was if you waited. So at 192 weeks, the patients on study, over 60% of them were on no steroids at all. And these were patients who required, as I said, 20 to 50 milligrams daily prior to the study. So this was really very exciting. Unfortunately, due to some problems with the study design, the FDA did not approve mepolizumab on this basis. One of the things that we found very early was that clinical subgroup might affect the response. And with Florence Rufos in Belgium, we looked at subgroup analysis of the LHES patients, and we were able to show that although they responded, 85% also responded and met the primary endpoint, the chances that their eosinophil count was completely suppressed was significantly less. Fei Lai went on to look in our compassionate use group. So these are patients that were not steroid responsive to start or had life-threatening disease. And what you can see here is, again, that when we divide by subgroup, the myeloid patients shown in the light color, the light yellowish color, did not respond to mepolizumab, whereas the EGPA overlap patients all responded, and the lymphocyte variant patients responded somewhat less well than the idiopathic patients. In eosinophilic esophagitis, the drug failed in phase 2 trials. The reason that it failed was for because of symptoms. Symptoms did not improve in these patients. As you can see here on the left, the number of eosinophils did decrease in the tissue, but there were eosinophils remaining. And this was true with mepolizumab or with reslizumab in adults as shown on the left, or in pediatrics as shown on the right. So anti-IL-5 antibody, excellent safety profile. We have patients that have been on drug now since 2002, and we really have not seen any adverse consequences. It's FDA approved for asthma, EGPA, and hypereosinophilic syndrome in the United States. I will note that the asthma dose is lower than the EGPA and HES dose that's approved, and that the dose we used in that phase 2 trial that I presented was actually 750 milligrams IV. So the lower dose was approved. It appears to be 85% effective in steroid-sensitive idiopathic and lymphocytic variant at that high dose, and it may be less effective in patients with more aggressive treatment refractory disease, like those with MHES who maybe have IL-5 refractory eosinophils, or patients with LHES who might have very high IL-5 levels. And the failure to meet the clinical trial endpoints in eosinophilic esophagitis could be because the eosinophils are not completely depleted. It could be because mast cells or other lineages are important and they're not affected, or it could be trial duration, irreversible structural changes in the esophagus, or other reasons. So moving on back to the case. The eosinophil count in my patient remained elevated at 33,000 despite steroids. She actually went on to require a second prosthetic valve surgery because of stenosis. She was then treated with high-dose steroids, hydroxyurea, Cytoxan, interferon, mepolizumab. She responded to nothing, and then was referred to us. When we saw her, we were just initiating a phase 2 placebo-controlled trial of benralizumab for HES, and we're considering her for this trial. So let me describe the trial. This was kind of a crazy trial. We enrolled 20 patients who had very aggressive disease. They all had to have eosinophil counts greater than 1,000 and symptoms despite being on therapy. They then were enrolled on a placebo-controlled arm for 3 months, where we were blinded to eosinophil count, and their other therapy was stable. They then got open label drug. After they received open label drug, we could see their eosinophil count and taper their background therapy, and then they could be extended. They underwent 2 bone marrow biopsies, 2 tissue biopsies, and I don't even want to say how many gallons of blood and numbers of visits. You had to be very sick to want to be on this trial. The primary endpoint was a reduction in eosinophilia after 3 doses of drug, and we had a number of secondary endpoints. So who were these patients? We had 13 women, 7 men, 23 to 74 years of age. They had all the different HES subtypes, including 2 patients with myeloid disease and 5 patients or 6 patients with lymphoid HES. They were on a wide variety of therapies: prednisone, interferon, hydrea, pulsed Cytoxan. 15% were on no therapy when they started the trial because they had failed all therapies, and their eosinophil counts were anywhere from 1160, which was 1,000 was what you needed to get on trial, up to 28,400. That patient was on 30 milligrams of prednisone. Their organ involvement is shown on the right, and you can see that they had a wide variety of organ involvement, including 20% who had had strokes and 15% with cardiac involvement. And the distribution of organ involvement correlated very nicely with the clinical presentation from Princess Abagu's study of the 188 multicenter patients. So what happened? Benralizumab was very well tolerated, and it was very effective in depleting eosinophils. So shown on the left is the primary endpoint, and you can see in the benralizumab group, almost all the patients, their eosinophil count went to 0. In the placebo group, the open dot is someone who dropped out of trial, and we said it was 100% response for statistical reasons, but he didn't respond. The other dot down here is the patient that I've been describing, and I'll tell you why in a second. And then the remaining patients, really most of them had very little change in their eosinophil count. If you look at what happened in the tissue, these are 2 patients who had esophageal and stomach involvement. At baseline, the tissues look horrible. They're filled with eosinophils. At week 24, after 3 to 6 doses of benralizumab, the tissues look normal. The primary study endpoint, as I said, was met. At week 13, when we could see the eosinophil count, 17 of the 19 evaluable subjects had an eosinophil count less than 50. And at 1 year, the eosinophil count remained suppressed in 14 subjects despite reduction or discontinuation of background therapy. This is what happened in the bone marrow. So pre-treatment, you can see lots of eosinophils and eosinophil precursors. Post-treatment, there were none. Interestingly, there was no effect on mast cells in the bone marrow, even though mast cells do express the IL-5 receptor. And there was a decrease in basophils, but not as dramatic as the decrease in eosinophils. Over here on the right are all the patients, and what you can see in the benralizumab group is the one patient who didn't respond to therapy and whose eosinophils in the bone marrow did not go down. So some additional intriguing findings. Both of the patients who failed had mutations in JAK2. One had a JAK2 V617F, one had an exon 13 JAK2 mutation. All 3 subjects who relapsed early had lymphocyte variant HES with CD3 negative, CD4 positive T cell clones. Although the drug was well tolerated, some patients really did have injection reactions with the first dose of study drug that we think was due to eosinophil lysis, but nobody had life-threatening reactions and everyone continued on drug. And some of the patients with eosinophilic gastrointestinal disease, although they're markedly improved, are not completely symptom-free. So the case that I was talking about was referred to us on interferon, mepolizumab, and pulse Cytoxan. Despite that therapy, her eosinophil count was 4,920. She had ground glass pulmonary infiltrates and severe restrictive pulmonary disease. Mepolizumab and interferon were discontinued. She was kept on the pulse Cytoxan and enrolled on trial. Because she was kept on the Cytoxan at week 13, because she was kept on the Cytoxan, her eosinophil count actually was decreased at week 12, and it was due to timing of the Cytoxan. But at week 13, after getting benralizumab, her eosinophil count was 0, cyclophosphamide was discontinued, and she's remained clinically well now for 6 years with an eosinophil count of 0 and no progression of disease. So where are we with targeting the IL-5 axis? I think we need to know how dosing affects response, both in mepolizumab and mepolizumab, which is fixed dose, compared to reslizumab, which is weight-based. Benralizumab for HES, we used monthly, but for asthma, it's given every 8 weeks. Which biologic for which patient? What if you give multiple biologics? One of the patients on our trial actually had ankylosing spondylitis and stopped his Remicade to be on trial. After he had been on the trial for 2 years, his ankylosing spondylitis got much worse, and he's now on both Remicade and benralizumab. You would think they would interact because Remicade should decrease NK cell function, but he's doing well on both. And so it's 10:20. I think I'm going to tell you about dexpramipexole because it'll only take a few seconds, and that's really, then I just have one slide before the end of my talk. So dexpramipexole is this very weird drug. It's a small molecule enantiomer of an oral drug used to treat Parkinson's that was found to be neuroprotective in vitro assays, and it looked great in phase 2 trials, but failed its primary endpoint. When that happened, the company was going to go bankrupt, and they looked to see what else it does, and they saw that it lowered the eosinophil count in 75% of the ALS patients for unclear reasons, and its targets unknown. So they approached us to do a proof of concept trial in 10 subjects with steroid responsive disease, which we did. They were started on dexpramipexole. They got 3 months of drug, and then we tried to taper their steroids to see what would happen. The primary endpoint was the proportion of subjects who could get to less than their minimum effective dose of steroids. The patients enrolled on the trial were varied, but did not include myeloid patients because they don't respond to steroids. They had a variety of organ involvement and were on up to 30 milligrams, of prednisone daily. So what happened with this trial? It was well tolerated. We met both our primary endpoints. 4 subjects were able to taper their prednisone to less than 50%. 3 of them had an eosinophil count of 0 after 1 to 2 months of dexpramipexole. and 4 subjects had a sustained response for greater than a year. We've seen no serious adverse events. Again, we have patients who've been on this drug for 7 years. I'm going to skip this. This was the one patient who received the drug, just showing you that her eosinophil count went to 0 and her tissue improved really completely on dexpramipexole. I think what's most interesting is what happened in the bone marrow. And this shouldn't say submitted at the bottom, this is in blood. But at baseline, the patient had a lot of eosinophils and eosinophil precursors. At 3 months on drug, we can still see eosinophil promyelocytes, but nothing beyond that stage. So dexpramipexole appears to cause a maturational arrest of eosinophilopoiesis. It does not do this to any other lineage, and we really don't know why. We're working with the company to try to identify the cause. So what are the potential implications of eosinophil depletion? So I addressed this at the very beginning. Impaired tumor surveillance, reduced response to vaccines has been shown in mice, metabolic abnormalities. To date, we really haven't seen any of these in our patients. And I guess I must have taken it out of this talk, but I think one of the most interesting things that we've seen was in the context of our benralizumab study, where we had a patient become pregnant. She had miscarried multiple times prior to being on trial, and she begged us to let her continue the drug. The data from monkey models suggested that it would be safe in pregnancy, so we went ahead and allowed her to continue on drug. She delivered a healthy baby girl at term. The baby was born with 0 eosinophils, having been exposed to benralizumab through the entire pregnancy, and didn't recover eosinophils until 9 months. Despite that, she's been completely normal and in fact has a normal response to all of her vaccinations at a year. So we think that this drug is really extraordinarily safe and that eosinophil depletion, at least in the short to medium term, doesn't appear to be associated with problems. So is there room for more new kids on the block? Absolutely. There are a lot of clinical trials that are ongoing. We've done work with Siglec-8 and dupilumab, but there are more coming down the pike. So in conclusion, I think understanding the clinical subtypes of HES is important because it impacts prognosis and selection of a therapeutic agent. Although eosinophils are the major driver of pathology in HES, other lineages may play a significant role, especially in overlap syndromes, and we can use some of these targeted agents to sort that out. Blood and tissue eosinophils are clearly not equal. Long-term reduction depletion of eosinophils in humans appears to be safe, and so I really think there is hope for our patients with HES. We have a number of ongoing trials. Some of them are listed here. And I don't know why things got shifted up and Princess Abagu is in the purple section, but I just wanted to thank all the members of my laboratory, even the non-clinicians who get sucked into these clinical studies, as well as the hematologists that I work with, Sandia and Cynthia Dunbar, the LPD clinical staff without whom the clinical studies couldn't run, and the companies that have all given us drug-free. So thanks very much, and I'll end there if there are any questions.
Thank you so much, Dr. Kilon, for updating us on this subject. Your lifelong research, you have educated us right up to what has been happening and what's expected in future. Number of these things we've been exposed for the first time. So we have our Indian clinicians and hematopathologists who will be asking and discussing with you, starting with Colonel Dr. Sanjeevan Sharma.
Hi, good morning, Dr. Amy. And it was actually a pleasure because long ago, I think it was in 2015 or 16, when I read your How I Treat Eosinophilia in Your Blood article. And I don't remember the year, but I think 15 or 16, I read How I Treat Eosinophilia. And it was a fascinating read that time also. And so many years down the line, to have actually hear you live was absolutely phenomenal. So firstly, thank you so much for this. So, my first question is based on certain in India, unlike what you are able to do in US, we do not have access to a whole lot of the molecular armamentariums for eosinophilia. Of course, between secondary and clonal, we do these FGF and the PDGFR mutations and others. but beyond that, probably not much. So our algorithm becomes very simple if we are able to exclude parasitic causes and this thing, we go ahead. But still, a large number of our patients who do have parasitic involved eosinophilia, they go on for ages. So, have you in your practice seen any differences in the organ damage which you see in a clonal eosinophilia vis-a-vis long-standing secondary eosinophilia, whether it is because of parasites or drugs or something else?
Yeah, so that's an interesting question. And sometimes, I thought about doing it and I didn't do it, but sometimes the two cases that I present are a case with tropical pulmonary eosinophilia that we saw in an Indian woman, and then a case of PDGFRA that we saw in an Indian man. And they present almost identically. The differences are that the patient with PDGFRA had involvement of other lineages. So he had anemia and thrombocytopenia, he had splenomegaly, and he had a markedly increased serum B12 level and increased serum tryptase level. So I actually have the reverse problem often talking to American audiences, that they focus on all the molecular testing and they barely even look at the patient, because they say, oh, well, we can just send the molecular tests. And I try to make the case that the molecular tests are good, but they miss things. And that really what's more important is the clinical picture of what you're seeing. So for me, the myeloid patients, they often have splenomegaly, but not always. They almost always have either an elevated serum B12 or an elevated serum tryptase, and those you should be able to get. They frequently have involvement of other lineages. So they might have anemia, thrombocytopenia. And when you do their bone marrow looks abnormal. They have clusters of abnormal looking megakaryocytes or dysplastic megakaryocytes. They have, so you find something that makes you think that this is what it is. In those patients, once I've excluded a parasite, and really the only one that you have to worry about terribly is strongyloides because of the possibility of dissemination. But realistically, if the person has hookworm and you give them steroids, big deal. I mean, yes, you should treat their parasites, but it's not going to make a difference. If they don't respond to steroids, then I would go very early with imatinib. And in a sense, that's a proof of principle. Now, some of the mutations clearly don't respond to that. FGFR1 doesn't respond to imatinib. We've had a couple of JAK patients respond partially, but not completely. But with those patients, then you'll move on to the next thing. You'll try hydroxyurea or interferon or whatever you have available, and you'll do the molecular testing that you need to do. But for us, that could really be a second step. In terms of other organ damage, it really is the same. I've seen pulmonary in both. I've seen endomyocardial fibrosis in both. I've seen colitis in both. So I don't know how to clinically differentiate. You think that IgE should be high in parasites and it should be low, and it should be low in a disease with mast cell proliferation, right? But that's not always the case. The very first PDGFRA I ever saw was from Sudan. He was an asylee. He had concomitant schistosomiasis. His IgE was elevated. And it got missed because they said, oh, he must have a parasite. He came from a refugee area. But he also had eosinophilic leukemia. So it requires a good clinician. And when things don't go the way you think they should go, rethinking, that's the most important thing.
And I think you've already partially answered my second query, which I had. I mean, what's the basis of using imatinib as a steroid-sparing agent, especially in those in which we are not able to find a FGF or a PTGFR mutation? I believe you've already answered partially that query of mine. Thank you.
Although what I would say is if you don't find a PDGFRA mutation, I would start with 400 like you do with CML.
Yeah, that's what we do.
And if it doesn't work after a month, it's not going to work. Give up and move on to something else. What I find is people will start and the eosinophil count will go from 9,000 to 8,000 and they'll say, oh, it's a response. That's not a response. It really has to go down. Otherwise, we move on to something else.
Thank you.
And then are you able to reduce the dose of imatinib in the maintenance period?
So for PDGFRA, so we treat everybody up front with 400 just because that's what we've always done. And our cure statistics are very good after 6 or 7 years of therapy. We've stopped therapy in a fair percentage of our patients, and we have a very high, over 80% cure rate. I think that's because we're starting high and then going low once they're in molecular remission. But we have the opportunity here to follow the molecular. The eosinophil count doesn't come, the eosinophil count can remain low while the molecular disease is still present. So if you can follow molecularly, then yes, we reduce the dose. Or if they have side effects from the therapy, we reduce the dose. Otherwise, if I can't do either of those, I actually don't reduce the dose because I don't want to. Ideally, you want to cure people. And we've had a few of our patients who had no mutation identified, who responded beautifully to imatinib, where we didn't reduce the dose, and then we've stopped after 6 years and they're cured. 2 patients, in fact. So,
do you ever try imatinib in female patients?
if they have PDGFRA or if they meet the myeloid criteria, yes. We've had partial responders, and we've had 3 women with PDGFRA. I have 1 girl. So I know somebody in the chat asked about pediatrics. I have 1 pediatric patient with PDGFRB. And so she's on imatinib. So yes, we'll try it in a woman if she meets the criteria, but it's relatively less common than I have a lower threshold in male patients.
In your talk, you mentioned about nilotinib. So all these TKI inhibitors are effective, is it? There is data on others?
There's data on others and they're not all effective. So nilotinib works if they're imatinib responsive and you're stopping it for toxicity. If they're imatinib resistant, nilotinib doesn't typically work. Sorafenib and dasatinib were both tried early on with patients who were resistant, and neither one of them works for PDGFRA. Whether it would work for some of the other things is really hit or miss. Midostaurin does work, but has more toxicity, and I don't know how available it is in India. It's not even so available in the United States. But if I have a patient who truly is resistant to imatinib and I think they need midostaurin or blue, I send them to Jason Gottlieb at Stanford because he can get the drug.
Thank you. Dr. Gayatri? Your video will not be on, but you can tell your question.
Dr. Agarwal, yeah, thanks for that. Apologies, my video seems to be running into a problem.
That's okay.
Thank you, Dr. Kilon. It was really very insightful, your talk, and somehow there seems to be so much clarity in your mind about this very perplexing situation clinically. And I have 2 questions which are interrelated. It's about I'm a pathologist, so I tend to look at that aspect of the problem. My questions are, how do we accommodate for eosinophil counts in areas which are known to be endemic for parasitic infections, especially like in India? We know that the general population is exposed to a lot of not only all other insulting agents, but also parasitic infestations. So would we want to redefine the criteria for eosinophilia and hypereosinophilia in these group of people? And my second question is also similar to this. In conditions where there is leukopenia for any reason, would we look at eosinophil counts, absolute eosinophil counts differently to define hypereosinophilia? Especially, pardon?
No, go ahead.
And another related to that is, if an individual is on drugs, which we know decrease the counts, how would we pick up hypereosinophilic syndromes? So all these are related to the numbers.
Right. So I'm going to answer them backwards because your second question is much easier. So we don't pay attention to percentage for exactly the reason that you're saying. And we really, we talk only about absolute counts. Now, that's not so easy in the bone marrow, as you know. In the bone marrow, you have to deal with percentages. But in somebody that has a low white blood cell count or has a hypocellular marrow, an increased percentage of eosinophils in the marrow without blood eosinophilia greater than 1,500, I don't worry so much about that. We do know that there are specific abnormalities that are associated with eosinophilia. So decreased T cells, so patients who've gotten chemotherapy, for example, or bone marrow transplant, when their T cells come back, they often come back oligoclonal rather than polyclonal. When that happens, they tend to have eosinophilia, and it doesn't matter. And so for us, the important thing in those patients who have low counts is, what do the eosinophils look like? If they have increased eosinophils, but the eosinophils look normal, they're granulated, they're bilobar, there's nothing particularly concerning, then we really don't worry about them much. However, if they're very dysplastic, then that would make me more concerned. The other thing that we found that actually associates with eosinophilic myeloid disorders is we do flow cytometry looking at mast cells. And when the mast cells, when you have systemic mastocytosis, they're typically CD2, CD25 positive. But in the eosinophilic neoplasms, including PDGFRA, they're almost never CD2 positive, but they are CD25 positive. And so far, all of our patients with eosinophilic leukemia have had CD25 positive mast cells. So for us, they're not absolutes, but all of those things together, are the eosinophils normal looking? Are the mast cells normal looking? All of those things tell us something about activation and make us more or less concerned about the eosinophilia. The other question is really hard to answer, because I told you about a case of Loa Loa and a case of tropical pulmonary eosinophilia, but there are plenty of parasitic diseases, toxicara in children, angiostrongylus infection, paragonomus. There are lots of eosinophilic infections that cause eosinophilia that cause eosinophilic end organ manifestations. So I don't really distinguish between a very high eosinophil count from a parasite and a very high eosinophil count from something else. But again, we look at things like, are the eosinophils activated? Does the smear look normal? In India, I would be somewhat less concerned about, or maybe not. I mean, so an eosinophil count in the US of 800 or 900, if the person has asthma, which is very common here, I don't pay attention to that eosinophil count, even 1100 or 1200. But once they start to get above 1500, it's really hard to attribute it to that. Parasites are a little different. They can cause eosinophil counts that are higher, but with the exception of things like tropical pulmonary eosinophilia, really high eosinophil counts like 20,000, 30,000 really are not due to parasites. But there's not a good answer for the middle group. I think you have to rely on your clinicians to give you an idea of what's going on. Like, where's the patient from? Are they, from an upper middle class family in New Delhi? They don't have a parasite. Are they farmers, in the South? Maybe they do.
Thank you.
Yeah.
I was especially concerned if these individuals remain asymptomatic. Do we label them as HES?
So that's what I was trying to talk about before. So if they're completely asymptomatic and they have no evidence of end organ manifestations, we would call them hypereosinophilia of undetermined significance. I don't know what to do with those patients, and I just follow them very closely. Many of them will remain eosinophilic for decades and never have a problem. I do always look to make if they have a really high eosinophil count above 5,000, they absolutely should have a bone marrow just to make sure they don't have a missed myeloid malignancy. Because those can be or the patient thinks they're asymptomatic, but really they're tired and they, maybe they don't feel well, but they don't think they don't feel well. So we do an evaluation, we don't ignore them, but if the evaluation shows nothing, then we just follow them. But I don't know what to do with that group of patients. It's really a clinician gut feeling. And so you have to rely on the people seeing the patient to tell you, yeah, this patient is totally fine.
Yes, Gayatri, anything more? Okay, so we move on now again to a clinician, Dr. Shilpa Bhartia.
Yes, good evening. I think you've partially answered the questions I had planned to ask was about this idiopathic eosinophilia. How deep do we go investigating these in especially asymptomatic patients? We do have access to getting an NGS panel for myeloid neoplasms, which is quite easy to get, or access to, other radiological investigations. So, before we could, even if they are asymptomatic, would we do an NGS panel just to make sure they do not have underlying mutations?
So,
yeah.
So NGS panels can be deceiving and they can show nothing and the person can still have something. Most of them don't cover the PDGFRA fusion genes, and we've had them miss JAK mutations, exon 13 JAK mutations. We've had them miss things even, at the best labs. So I think they're useful if you think somebody has a myeloid disorder, but we don't do them unless we have a suspicion. We really rely on some of the simpler things to identify the patient. Are they steroid resistant? Do they have splenomegaly? Do they have elevated serum B12 and or tryptase? Do they have anemia? We take the whole picture and we use that to decide whether an NGS is something we want to pursue. Because we do whole genome on every patient we see, and I can tell you that lots of people, you'll find a Runx mutation. Well, but it's a VUS, so what do you do with that? And did it really help me? No. So I don't really know how to interpret them either on one side or the other, unless you find something really classic, a mutation that's really pathogenic. And so I think the value is outweighed at this point by the cost and by the uncertainty that you might start.
And when we're looking for the end organ damage, is it purely based on the symptoms that the patient presents with, or would we do like an echo and HRCT and, perhaps looking more strongly for colitis by sort of investigations, or it would be based purely on symptoms to say whether or not they've got end organ damage?
Yeah, so some things it's symptoms. So GI involvement, if somebody doesn't have clinical symptoms of any kind, they don't have GI involvement. So that's easy. The things that we do, everybody gets an echo, because somebody in good shape can have pretty bad cardiac involvement and not even know it. And we've had that happen. We sent somebody to transplant. He had an EF of 32% and he was riding his bike 10 miles a day. So I've been fooled too many times for that one. So we do an echo in everybody. In the US, because of pulmonary involvement with asthma being so common and a cause of eosinophilia, we do pulmonary function tests in everybody. I'm not sure that that's absolutely necessary, but we do. And then I feel really strongly about anybody with eosinophil count greater than 1,500 should get a CT once. And that includes pediatrics, and I'll tell you why. Last week, or actually 2 weeks ago, I saw a patient who presented because she went to her dermatologist, she had acne, and she went to a new dermatologist and they prescribed Accutane. She started and so they got a CBC and her eosinophil count was 10,000. And so the dermatologist stopped the Accutane and they did a workup, including a bone marrow. They found nothing. They put her on, she was completely asymptomatic. They put her on steroids. We normally would not put a completely asymptomatic person on steroids. They put her on steroids. She didn't really respond. Her eosinophil count came down to 3,000 and they followed her for 6 months. They referred her to us actually early on, but we couldn't see her because of COVID. I finally saw her 2 weeks ago. We did a chest, abdomen, pelvis CT. She has a mass in her mediastinum. We just got the biopsy result. She has Hodgkin's lymphoma. She's 14. So pediatricians here often they balk at the idea of CT scan. That's one case, but I've seen a dozen like that. So we think that CT scan can be really helpful. In an elderly patient, you're looking for occult cancer. And so in those patients, I would make sure adenocarcinomas can drive eosinophilia. So in an elderly person, I would make sure that they've had their routine colonoscopy, that they've had their mammogram, and they've had a usual evaluation. Men have had their, prostate checked. In children, they can get lymphomas and be completely asymptomatic. So we'd always do a CT.
Would a PET CT be easier instead of multiple CTs and multiple sites of, not in a child, but maybe perhaps in an adult? Is that
Not
the way
in the
we'll be
US.
going?
It's so much more, it's more expensive and harder to schedule. So and our CT scanners are low radiation. So the amount of, we do chest, abdomen, pelvis all at once, and the radiation is very low. So we choose, I think it depends on where you are. But yes, a tumor should light up, and she lit up, her SUVs were 20 on PET scan. We did get a PET scan as a second step.
Okay, thank you. Thank you very much.
Shilpa, we move on to the hematopathologist, Dr. Jyoti Patwa.
The first question I had in mind has already been answered. That was the role of NGS, because we keep on getting patients for eosinophilia workup to the laboratory, and the clinician has done an NGS and say, now what else? So that's one issue that you have already answered. The other question I had in mind is that someone where reactive causes have been ruled out, myeloid variant has been ruled out, the routine workup, PTGFR beta ruled out on cytogenetics, PTGFR alpha, FIP1 by RT-PCR. We do it in our own lab also. And a flow cytometry has been done for the T subset, and nothing found phenotypically. But on the bone marrow, there is an increase in T lymphoid cells, more than normal, for that age and that particular person. So does it have a prognostic significance, or would we want to go in for further workup?
Yeah, so what we do, and I should have mentioned that probably, is so we do flow like you do. We also look for T cell receptor clonality by PCR. Because what we found is, and we published a couple of cases of patients who had normal T cells by flow and their surface markers. But when we've done the T cell receptor rearrangement analysis, they actually do have a clonal T cell population. One of the problems is that the other way you can look at that is with V beta, with the V beta IA test, but the V beta IA test is, at least for us, it's $2,000 or $3,000, whereas the PCR is cheap. And so we do the PCR as a screen. When we've then gone back and looked at the patients who had normal flow and a clonal T cell population by PCR, just because we're a research institution, we then go back and do V beta IA test. You can see the clonal population. And then if you look at that population, if you gate on that V beta, you can see that they're making IL-5 and IL-4. So we do know that if you have those populations of cells, if you have a phenotypically aberrant population, you're at increased risk of lymphoma progression over time. If you have just clonal by PCR, but no phenotypic abnormality, you have an increase as well, although less than if you have a phenotypic clone. And if you have neither of those two, you're very unlikely to go on to develop lymphoma. So it is important to sort those patients out. You wouldn't necessarily treat them differently. So for the clinician, they might treat them like an idiopathic HES. But I think it is important to know so that you know what to follow.
And there's another case I would just like to discuss, because it happened, this individual, he was high socioeconomic strata, he was a politician. We got his marrow from a referral hospital. We reported it as hypereosinophilia. He was being worked up by a clinical hematologist, seen by 3 clinical hematologists, didn't respond to steroids, didn't respond to, then they gave him some imatinib, didn't respond, was put on hydroxyurea, then that was stopped, and he was on interferon alpha, which he was not tolerating. And in this situation, he was a politician. He went and met a gastroenterologist who happened to be a friend. So he said, and that time we had started these, just started this was around 2 years back, the subset analysis for eosinophilia. We read your articles and the other articles, and we were, standardizing it in our lab. And he was referred to me by this friend. And he walked into my office, and I saw that he was from Northeast. And I have been in the military before coming to the private for 30 years, and I have been all over to the Northeast. So the moment he walked in, I asked him for his reports. He had a CT scan, he had some pleural effusion, lung involvement, his echo had given his ejection fraction was low, and that's why he was on treatment for almost 1.5 years. And I just asked him, I said, you are from Meghalaya, so do you by any chance have raw crabs and prawns? And lo behold, he said, yes, I am very fond of alcohol. And in our place, we believe, and someone has had cirrhosis in my family, that if you dunk the crabs in alcohol and then eat them and then drink that alcohol, you don't get cirrhosis of the liver. So this was a high socioeconomic strata, a politician from one of the states in India, Northeast state. And that's when I said, oh my God. And I immediately went into the Google P. Westermanni, and I
drunken
said,
crab.
that. So he said, yes. And we could not get any private or government laboratory to give us the antibody titer for this. So that was the state. And they said one in Dibrugarh does it, but they said we have stopped doing it. And then we just, he was given a trial of praziquantel, and he got out of it. So and he had been getting all kinds of drugs. So sometimes it happens in our country that how deep we go in for the secondary causes before working up for everything else becomes an issue.
No, it's not your country. This is all over the world. So that's why I think you really have, I mean, what I tell all the fellows coming through is the most important thing you can do is rule out secondary causes, is take a good history. Because rather than, I mean, I saw a patient referred by a dermatologist who had been on prednisone, cyclosporin, and Cytoxan, and he had scabies. We treated his scabies, his eosinophilia went away. So, you really have to think about what are the causes and address them. So I'm glad that he got treated. I'm sorry he probably has permanent cardiac damage because somebody just looked at him and said, oh, it's a politician, he's wealthy, he couldn't have a parasite. It's not true.
They treated him for routine. They gave him a course of hetrazan for filariasis and all, but they never thought in terms of
things he might have done.
It just happened when he walked in, and I saw he was from the Northeast and had been to those parts of the country. So being in the military for many years before working now out in this private sector, it happened.
Thank you. Dr. Deepanjan.
Thank you. Thank you, madam, for the wonderful talk. My question is again related to pediatric hypereosinophilia. So I want to know about the long-term outcome and prognosis of such patients, and how long do you continue these patients on, like do you go for any definitive treatment like bone marrow transplantation, and when to take that call? So I have a patient with 9-year-old who was seen for severe eosinophilia with the absolute eosinophil count in the range of 30,000. We worked him up. He had a clonal chromosomal abnormality, and his NGS detected CNTRL FGFR1 fusion. And he was treated with steroids, hydroxyurea. There were short responses, but on trying to taper down the steroid dose, again, the eosinophil count used to go up. We gave him a trial of imatinib, but he was imatinib refractory. So what should be the long-term approach for treatment of such patients?
Yeah, so a patient like that needs to be transplanted. There's no other solution. I mean, unfortunately, so let me first say, and I know there was a question in the Q&A also. So the causes of eosinophilia in children versus adults, at least in the United States, are very, very similar with a couple of exceptions. So one of them is immunodeficiencies. So primary immunodeficiencies and genetic disorders are more commonly picked up in childhood. And, not just DOC8, which is one that people might think of, or Job syndrome, but many of the immunodeficiencies can present with eosinophilia. So we think about those. In countries where parasites are endemic, you also would most likely see parasitic causes a little bit more common in children, although generally those, with the exception of Toxocara, would be more benign. But other than that, we see it's really the same across the board. So if you look at myeloid disorders, we've seen PDGFR A and B and chronic eosinophilic leukemia in children. We've seen lymphoma presenting as eosinophilia in children. Idiopathic seems to be the same. Children tend to have a slightly higher eosinophil count with the same disease. So if you take an adult and a child with asthma, the child will have a little bit higher eosinophilia. They seem to be more reactive, but we treat them exactly the same. Almost none of these disorders are curable. They almost all require long-term therapy. And so if that long-term therapy is not really, either isn't working or is not compatible with long-term, then you have to think transplant early in children. There's been pretty good success with low intensity transplant for some of these. You have a patient with a myeloid neoplasm with a clonal abnormality, so that may not work. But yeah, I think that's the way you would go for that patient. We have occasionally, I'll put the myeloid patients aside. With idiopathic HES, we have occasionally seen children when they go through puberty, the disease goes away. And so I wouldn't necessarily, unless they have life-threatening disease, think about transplant outside of the myeloid category or a patient with lymphoma or an immunodeficiency. I wouldn't think about transplant. I would try to get them through to puberty and just see if it goes away. We similarly see that happen sometimes when women go through menopause or in the context of pregnancy. So yeah, but your patient, you have very little to offer. None of the other drugs are likely to work long-term, and you're not likely to cure that patient without a transplant, but that's a difficult decision.
Thank you.
Thank you, Deepanji. Dr. Swati Pai has a case for presentation. Can I ask Nirav to project her slides? And Dr. Swati, over to you.
Hi, Dr. Amy. Am I audible?
Yes.
Yeah, okay. Hi, so it's a coincidence that we just had a case a couple of days ago, and I asked Dr. Agarwal whether I could put it up for discussion. Can Nirav give you the slides?
We have a slide.
Yes, ma'am. I'll just load it.
Yeah. So I'll just give you a brief background. This is just a slide that was sent to me. It's a peripheral smear. I will show you the picture sent from a pediatric hospital. It is a 3-year-old male patient who has fever for 1 month with increasing counts, a history of left-sided knee pain with query surgical drainage of pus. I don't know how relevant that history is. Was referred to a tertiary center in view of the increasing leukocyte count, which is not my hospital.
Right.
And the patient has hepatosplenomegaly. So this is the smear. Nirav, can you give me the next slide? Yeah, so this is a stain slide that I received. I'm not responsible for the staining, but you can see on the low power, there are plenty of eosinophils, a lot of them. And as you said, the eosinophils are beautiful, but then along with the beautiful eosinophils, there were some ugly cells. 1, 2, 3, 4. So this child had a hemoglobin of 10, a total count which was very high, persistently rising eosinophil and eosinophil precursors, and blasts which were not more than 11-12%. Platelets fairly okay, not very low. So I asked them to do a bone marrow and send it to us, but they did not do a bone marrow. They did a bone marrow. I just got the report today, but didn't send it to us. So I was waiting for them to send a sample. At this stage, what would be your likely diagnosis for a 3-year-old child? No skin rash, no nothing, no other symptoms except fever and hepatosplenomegaly.
I think the thing to be concerned about is the possibility of pre-B cell ALL. We've seen that present in this way, where we thought that a patient had a myeloid leukemia, but it turned out to be a pre-B-cell ALL, and the blasts, because the counts are so high and the eosinophils are so high, sometimes the blasts appear not to be so high. And even when you try to look at the B cells, especially in young children because of the number of hematogones, you sometimes are not able to show the abnormality. We've even had it happen that you send fish and the fish comes back negative. But the child progresses and that's what they have. So what we do in those cases, which seems to be a little more sensitive, is again, we look at B cell clonality by PCR and look for IgH rearrangements. And those are typically clonal in these patients, even if everything else is negative. But that would be kind of top of my list. We've seen that really quite frequently, and they're difficult to diagnose. And then suddenly they start to develop eosinophil complications. The boy that I presented in the presentation who had the high counts, he actually, because the hematologist didn't want to treat him without a positive cytogenetic or increase in blasts, he went on to develop cardiac involvement and endomyocardial fibrosis before he eventually got chemotherapy. And so this is a difficult diagnosis. I guess it's possible that it's a myeloid leukemia. They're very uncommon in children. But so this would be the kind of patient where sending an NGS panel would be useful. When I see, so your platelet units are different than mine. So is 1.34 low or high?
It's in the almost normal.
Normal? Okay. Yeah. So I was going to say, if the platelets were high, then I worry about unusual JAK mutations. For the way that we report is a little different. For me, that would have been, I don't know what LAKH is. Anyway, that's fine. So
100,000. So yeah.
Okay, no, that's no problem. So, but yeah, with anemia, with just anemia and this kind of picture, those would be the things that I would worry about. It's possible that this is something that if he really did have an infection in his knee, they need to make sure that this isn't something like DOC8. They sometimes will present just with eosinophilia. Does he have a very high IgE?
So we have nothing except the slide, but because I wanted to put it up for discussion today, we managed to get hold of where they could have possibly sent. I'm from Bangalore. There are not very many places where they could have sent the marrow and the genetics. And I found the flow reports that they had sent to a standalone lab. I'll just read out what they reported. They said they had only 20% blast and rest were all eosinophils. There was no maturation. The blast express CD34, 38, 33, CD13, CD117, 123, CD4, CD56. No MPO, no cytoplasmic CD3, no cytoplasmic 79A. But they called it M4 with inversion 16. There's no MPO. So yeah. I'm going to discount their report, but let's assume that their marker expression is right. They have 4, 56, 123, 34, 117. So, so it's clearly not lymphoid.
Right.
You go by 4, and nothing else. So.
Yeah, I think you need to do, I think they need to do molecular testing, and look at IgE. If you don't find any, and they need to test for primary immune deficiencies because they can sometimes present this way. If there's a really strong, with like a pseudo leukemia picture where they have just a strong drive towards eosinophils, you can sometimes see this. It's a little bit less common. I don't know. Without the information, it's really hard to say.
And then we got their AML fish panel report, which was sent to a lab in Bombay. That says that they have everything negative for the AML fish panel, but they put a note that they see trisomy 21.
Trisomic 21?
Yes.
Ooh.
So this is a 3-year-old child who has 21% blasts in the marrow. The blasts are clearly expressing myeloid markers, but not MPO. And the AML fish panel is negative, has trisomy 21. With all this eosinophilia. So I have never seen a case like this, and I wanted your inputs.
No, I mean, I have not either. I think I would have to, so this would be, I would start looking in the literature and searching trisomy 21 and eosinophilia and see what I find. But no, it's an unusual case. And these cases in children are particularly difficult. They often have very unusual things. But I would be very worried with this kind of count that this child's going to have something happen to them and that they need to do something to bring the counts down. And if they're refractory to steroids, I mean, if the counts start to get towards 100,000, we kind of feel like you need to acutely lower them in some way, especially if they're activated. The one thing that's a little weird is that the eosinophils here, at least in the right, where I can see them clearly, they look completely normal.
Yes.
I mean, they really don't look dysplastic at all. And that's the thing that's a little unusual, that's making me think that even though everything is sort of pointing to a myeloid disorder, maybe this is not, maybe it's not. And so I would still look at IgE. I would do the B cell markers, even though the markers on the blast that they reported to you sound inconsistent.
Do you think they should have done megakaryocytic markers as well? Because now that we have trisomy 21, they haven't put any 41, 61.
Yeah.
So
I mean, I don't think there's a downside. Like I said, I'm not sure what this is.
Thank you. We'll move on to Dr. Varun Bafna. Dr. Varun, are you there? Okay, probably he has logged out. We have some questions from the audience. Would you like to take them?
So I was just answering the first one. I typed the answer, which I think that I had answered. The second question about HES in children, I think I also answered, and I would worry about children the same way I worry about adults, but I wouldn't worry quite. I think in India, depending on where the child was from, I would worry about parasitic helminths in young children that are in rural areas. But otherwise, I would worry the same way that I would with an adult for counts greater than 1,500. See a lot of you. So the question about CML. So I'm not a hematologist and I don't treat CML. I will say that I have not been referred a patient with CML with persistent eosinophilia on imatinib. So I don't know, but I've not heard of that. And so that would make me wonder whether it's related to something else. And imatinib does not typically, so that I can answer because we have a zillion patients on imatinib, and that as a drug is not particularly associated with allergic reactions and with eosinophilia. So I would wonder if those patients might have something else going on, but I don't know what that is. I think they would need to be if the eosinophils are not causing trouble, then maybe I wouldn't worry. But if there's any evidence that they are, then I would be concerned about that. But I have not seen that. The next one is, when do you stop treatment with steroids in idiopathic HES? In case of relapse, how do you treat? So I think I addressed the when do you stop treatment, which is essentially never. We're continually trying to taper people to the lowest dose that will suppress their eosinophilia. So we don't just leave people on steroids at 30 milligrams. We always are trying to taper. So the times we have had a few patients go into permanent remission. The way we found them is we taper and their disease doesn't come back. If we're able to taper them off very slowly, then we follow them quite closely for at least the first year for relapse. We've had patients relapse out to 2 years. And if they relapse, we treat them exactly the same way. What happened? When do you do a bone marrow in HES? I kind of think that anybody with sustained eosinophilia greater than 1,500 deserves one bone marrow. I wouldn't necessarily repeat them multiple times if they don't show anything. And we look for everything. I mean, so we obviously look for eosinophilia, but that's oftentimes the least helpful thing. We look for evidence of dysplasia. We always look for mast cells. We do special staining with tryptase or KIT to look at mast cells and whether they're spindle shaped. We look at megakaryocytes. We look for lymphocytic collections, we look at cellularity, we look at fibrosis. So I think you characterize the marrow the way you would for any other disease. And that can often be very helpful and point you in a particular direction. So the next question is, I have a patient with HES, initial eosinophil count 56,000. They gave hydroxyurea, steroids, and Helminth treatment. I hope you didn't give him Helminths, but you gave him treatment for the Helminths. Didn't respond well. Then imatinib was given. The count was reduced and he developed thrombocytopenia. We then reduced the dose of imatinib and he's doing well. Yeah, so this is exactly the kind of case that I was talking about. So this patient may have an occult PDGFR A or B mutation, especially if their counts went to normal. With the thrombocytopenia, we typically stop the drug and then you can often go back to the initial dose and they do fine, but it's okay if he's still doing well on the reduced dose. We would treat for a minimum of 5 years before we stop. Everybody we've stopped earlier than 5 years has relapsed, and about 80% of the people that we've stopped after 5 years have been in sustained remission. In a case of few systemic mastocytosis and associated hematologic malignancies, post-treatment saw eosinophilia. How do we treat these? So if they have eosinophilia with systemic mastocytosis, that's usually very aggressive disease. And you treat them as you would treat systemic mastocytosis. You generally don't treat the eosinophilia separately. We've not seen a case of KIT together with PDGFRA. I guess it would be possible. We've seen FGFR1 with PDGFRA. So these mutations sometimes can occur together. So you would have to, in that patient, I would definitely do an NGS panel and I would look for the other mutations, even though you found KIT, to see whether there's something else going on. But unless you found something else or the eosinophils were causing clinical symptoms, I'm not sure I would do much. We've had a few patients with eosinophilic GI disease and systemic mastocytosis where we've treated them with swallowed steroids or dietary interventions, and that has worked. So you can have eosinophilic disease, again, like that other patient, that's separate completely from the underlying disease, and so maybe trying to relate them is not the right way. The next question, 65-year-old male, 1 month back, had pneumonia, abdominal pain, oral ulcers, then developed pancytopenia, bone marrow was hypocellular, EBV PCR, doesn't say, it says EBV PCR and AM. So I don't know what that means. IgM positive, recovered after antibiotics, 2 doses of GCSF, again having ulcers with 23%. Now EBV PCR is negative, parvo negative. So this is a very complicated case, so I don't think I can answer you. What I can tell you is that we've seen chronic active EBV infection driving a lymphocyte variant HES that progressed to lymphoma. When I see EBV positive patients, I worry about lymphoid malignancies. And so that would be one thing that I would worry about. The pancytopenia is a little bit atypical, so I don't know what to tell you about that. This looks like a very unusual case. I am available if you want to send more detailed records. You can email me records and I'm happy to look at them and see if I can give you a better answer. But that's not very helpful. Your experience with ruxolitinib in HES, we have an ongoing trial. We've treated 13 people with ruxolitinib with different types of HES. And I think for patients with lymphocyte variant HES, the results are looking really good. It, however, does not prevent progression to lymphoma. So the first patient we treated with ruxolitinib had terrible skin involvement in a big clone, was resistant to steroids and to interferon. We put him on ruxolitinib, his skin disease melted, he did beautifully for a year, then he presented with pulmonary infiltrates and had a T-cell lymphoma. He actually was transplanted and he's doing well. We've seen some idiopathic patients also respond, particularly those with skin involvement, but it really does increased susceptibility to infection, especially to TB. So I would be a little bit more concerned in India than I would here because of that. They do get bacterial infections. We've seen that a number of times. So it's not a drug without risk, but for somebody that fails everything else and who doesn't have hepatitis or a latent TB, I think it has the potential to be a good drug. I know Jason Gottlieb is also doing a study. We've treated a couple of myeloid patients unsuccessfully, and then we have one myeloid patient who's doing quite well. So I don't know, the ones with translocations in JAK don't seem to respond. The ones with point mutations look maybe like they might respond better, but there's very little data. Can you explain the difference in sensitivity and specificity between RT-PCR and FISH? Yeah, so FISH, you're counting cells. So your limitation is if you count 100, if you count 20 cells or 200, even if you count 200 cells, you can only detect one cell. And PCR, if you do a nested PCR, which is what most of us do, it's more sensitive for picking it up. So in that situation, we know that it's more sensitive. Both tests have a problem though. So if you're doing PCR and they don't have FIP1L1 as their fusion, and there have been other reports of other fusion genes, you're not going to pick it up because you're not going to get the other side. Or if they have a point mutation, you're going to miss it. With the FISH, you might see it, but it might get missed. So if they have another fusion partner, but you're not using a probe for that partner, then the interpretation can be somewhat difficult. And if it's a point mutation, you're going to miss it as well. So both tests are pretty good. We see about a 30% miss rate on FISH compared to PCR, where we've done both. And so I think that's the explanation. But I would rely on your clinical clinical suspicion and use that to guide whether you start imatinib or not. The next one is, what is the time point to check molecular remission with imatinib? Varies. So hematologic remission is usually within a week. Everybody has responded within a month. Molecular remission, we've had the longest time it's taken for someone to go into molecular remission for us was 18 months. That was actually what my Indian patient who presented with what looked like tropical pulmonary eosinophilia that turned out to be PDGFR-A. He took 18 months on 400 milligrams to go into remission. He's now been off therapy for 7 years and he's cured. So it doesn't seem, we haven't seen it that it matters, which is why we keep everybody on therapy for that length of time. Are Charcot-Leyden crystals in the bone marrow surrogate markers of eosinophilia? Yes and no. I mean, Charcot-Leyden crystals are from eosinophils, and if you see them, yes, it tells you eosinophils were there. You can also stain for eosinophil granule proteins, and that'll tell you eosinophils were there. But lots of people don't have Charcot-Leyden crystals detectable, so it's kind of just an interesting and pretty phenomenon, but not so helpful in the real world. What's the role of doing parasitic antigen assays? Yeah, so parasites, so that's what I am. I'm a parasitologist. Parasites are really a problem. So strongyloides, there is no antigen assay. You can do PCR in the stool. You can do concentration methods in the stool. They're not super sensitive. You can do serology in India. That's too sensitive. Everybody's positive and it doesn't become negative with treatment. So filariasis, the antigen assay is really good in everything except tropical pulmonary eosinophilia, where 50% of the time it's negative, but antibodies are sky high. Ascaris, look for eggs in the stool. I mean, every parasite is different. What I will say in response actually back to the case that was brought up that was paragonymous, Mahidol University does most of the serologies. And so we send to them when we can't get it in the United States. I don't know about the politics from sending them from India to Thailand, but they actually do almost all of the serologies and are very reliable. But every parasite is different. So you need to talk to your ID colleagues and ask them what is most likely, and then do the test that is appropriate for that parasite. Next one, CML AP 46XY with some horrible cytogenetics on nilotinib since 2 years in MMR. Ooh, things keep moving. in MMR having total leukocyte count 12,000 to 15,000, always with eosinophils 1,500 to 1,700. I have no idea. I mean, I don't know how important so the total count is very elevated. The eosinophil count's a little elevated, but not very dramatic. I would wonder if that's just because the total is not what's driving the disease, that it's truly a CML. So I think you treat the CML with whatever you need to do. And if they don't respond to, oh, I see, in major molecular remission. So, and now they have, so this is another one of those weird ones. I don't know. We haven't seen this. So I would either, if the patient doesn't have evidence of eosinophilic damage from 1,500 to 1,700 and they're in molecular remission and the CML seems like it's gone, I would just ignore it. But those counts are not normal, even if you take the eosinophils away. So something else is elevated. That would be what I would be worried about. How do dysplastic eosinophils look? Very ugly. They look, they have cytoplasmic clearing, so those beautiful red granules are not all nice and packed. They have areas that are cleared or that look like they're moth-eaten. Their nuclei, instead of having a bilobe nucleus, they look like neutrophils. They have multiple lobe nuclei. That's pretty much how they look, not as nice as they normally do. I'm trying to keep in line here. The questions keep sliding. How do you treat recurrent lymphoid variant HES? Yeah, lymphoid variant HES is very difficult to treat. We normally start with steroids. These days in the United States, our second line would be mepolizumab, which works pretty well for those patients. If you don't have access to that or the patient doesn't, which is common in the US also because of expense, second line for lymphoid variant would be interferon if they don't tolerate it and it recurs. Cyclosporin, methotrexate, we try everything. There's no good answer. You just try things until the patient tolerates the drug and it keeps the eosinophils down. How to differentiate between pH-like BALL with PDGFRA rearrangement from yeah, I don't know, and I'm not sure that it matters. So if they have a PDGFRA mutation, we would treat with imatinib. And my understanding is that even the ones that present with a BALL-like picture that have a PDGFRA arrangement should respond. If they don't, then, or the eosinophils respond, but the B-cell ALL doesn't, then I would treat them as you would treat BALL. How do you explain adolescents improving eosinophilia? Wish I knew. Hormonal changes seem to affect eosinophils. I mean, they affect the immune response in general, right? So diseases like lupus often get worse or better during hormonal changes. But why that? That's a good, if you want to study something, that's a really good thing to study because nobody knows. On pre-anesthetic workup, if we find eosinophilia more than 1,500, what should we do? And precautions during surgery. If they don't have any end organ manifestations, I don't think I would do anything. If that's the way they are normally, I would just, and they need surgery, I wouldn't worry about it. But that should be a hint that there's something going on. And so that should be investigated. But if they need emergency surgery or urgent surgery, I would just ignore it. Can we use a combination of serum total IgE and Fadiotop for excluding allergy? Fadiotop's not very helpful, and allergy doesn't, I mean, allergic disease can cause mild eosinophilia, but again, somebody with more than 1,500, children, maybe 1,500 is okay, but more than 1,500 in a child, I would, even that, I think, you need to think, is there something else going on? If they have very severe allergies and an eosinophil count of 2,000, is it okay? Maybe, based on clinical experience, I would see that child and say, you know what, I don't think it's anything, but I think you just have to use clinical judgment, but I don't think Fadiotop is very helpful. How do you look at eosinophilia 3 months post-autologous stem cell transplant? Yeah, so that's really interesting. So I don't know, and we've seen that quite a bit. Often it's transient, so we don't do anything about it up front. Oftentimes it's transient, it goes away. We always worry that if they presented with eosinophilia as part of their Hodgkin's, that recurrent eosinophilia might be recurrent Hodgkin's. But if you've evaluated them and you know that that's not the case, then there's really interesting data from mice where they took mice, they irradiated them, and then they gave them back T cells. And if they gave them back a full complement of T cells, those mice had no eosinophilia. If they gave them back oligoclonal T cells, all the mice developed eosinophilia and many of them had GI eosinophilia. So we think that, especially with Hodgkin's, especially if they got radiation, you can have a post-treatment eosinophilia that's just due to immunodysregulation and doesn't cause any clinical problems from the eosinophils themselves. They're just normal eosinophils and due to an imbalance. In that case, we do nothing. But I do worry about, could this be outgrowth of a clone? Could their lymphoma be recurring? Is it okay to treat empirically with antihelminthics? You can, if in the right setting. I wouldn't do it with everybody, but we sometimes will treat with antihelminthics empirically. The problem is knowing what you're treating. So are you going to give ivermectin, albendazole, praziquantel? Are what are you treating? What's the most likely thing? And are you going to add DEC if they're from an area with filariasis? How long are you going to treat with albendazole? Toxicara, you have to treat 3 weeks. So it's not like giving a single dose is going to solve all your parasitic problems. So yes, it's okay. The eosinophil count, if you're treating a parasite, will often go up at 10 days to 2 weeks. We sometimes use that as a marker that we've treated something real. But it often doesn't go away for 3 months. So if you need to deal with your patients sooner than 3 months, you can give them antihelminthics. I would make sure you give them ivermectin if they're at risk for strongyloides, and then you should probably just address their eosinophilic disease as well. I'm looking to see, I think that may be all the questions. I think that's the questions.
Right.
I'm sorry if I missed one. I don't think so, but I may have.
You have said almost everything. Thank you so much. So what should I say? This was a lovely session, great lecture, great Q&A session. You answered all the questions of the faculty here as well as from the audience. And we have a huge number of audience across the globe who have logged in. There are people from India. There are people from almost 15 countries all around who have been listening.
Oh my goodness.
So thank you so much for doing this great job. You educated us, and this is going to help in practicing and treating patients. So all your experience, great, fantastic.
Well, thank you. I'm sorry about the technical difficulties at the beginning. I hope, I'm glad everything was fine at the end. But it's my pleasure. And like I said, I'm always happy to answer questions by email. I will not, it's hard for me to give specific patient recommendations without seeing, these are complicated patients, but I am more than happy to give more general recommendations, or if it's very clear, then sometimes I'll give specific patient recommendations, but it's a complicated topic.
Thank you so much, and have a wonderful day ahead. Thank you so
Thank
much.
you. You too. All right. Bye-bye.
Everybody, and good night to all from India.